Hey everyone, I wanted to make a little video about pulmonary hypertension, especially in the ICU, and what we should be concerned about, what we should understand about this condition within the ICU. So let's begin. Let's put a title to this. I'm going to say pH in the ICU. Okay, so pH means, what I'm saying by pH, it means pulmonary hypertension or increased pulmonary artery pressure. All right, so that doesn't really tell me much, but we'll also define this further by mean pulmonary artery pressure. Okay, so just like our systemic circulation, we're really concerned about our mean arterial pressure. Well, we're concerned about our mean arterial pressure. So some accepted abnormal values of this that are clinically relevant are greater than or equal to 25, okay, at rest, and or greater than 30 during exercise. Most of the time you're going to be seeing this in patients at rest because they're very sick. But in critical care, remember I discussed the concept of your normal abnormals. We're not really concerned about this value as much as threshold with patients who are critically ill. As you'll see in this discussion, there's a lot of things that contribute to increase in pulmonary artery pressure that will go well beyond this physiological level that we've established here. But it is something to keep an eye on, okay? So also, how do we measure this, this value here? Well, we can measure it with a pulmonary artery catheter, okay? Which we discussed in our previous module. So let's go into some of the parts of the whole with this, like I like to do. So let's add some math to this. So if you compare this to Ohm's law, which is very similar to a lot of concepts we use in our profession, you have V equals I times R. All right, let's make this into terms that we use. So we're gonna, for V here, we're gonna say our delta P. All right, I'll establish these pressures in a second. And then for our flow here, we're gonna use our flow as our cardiac output. Then times our resistance, which is gonna be our PVR. All right, so this equation actually equals for us our mean pulmonary artery pressure minus our pulmonary capillary wedge pressure. All right, because remember that estimates the left atrium. Let's see where I am here. Equals cardiac output times PVR. PVR meaning pulmonary vascular resistance. Okay, so let's pull this down here again, and let's isolate mean pulmonary artery pressure, because we want to know what causes this. Because like I said, if you just say pulmonary hypertension, that doesn't tell me anything. So let's look at the parts of the whole. So let's go over here and let's isolate our mean pulmonary artery pressure. So algebraically, this will work out as cardiac output times PVR, can't write R's today, plus our pulmonary capillary wedge pressure, okay? Or our left atrial pressure. And these are the things that contribute to an increased pulmonary artery pressure. So cardiac output, I'm not too concerned about. I talk to a lot of physicians about stuff like this, and you see all these values, and you're like, what should I really worry about? Well, cardiac output, we can control that with drugs. We can control that with fluid and things like that. Pulmonary vascular resistance is the most important part of this equation as far as its contributions to pulmonary artery pressure, and then the cardiac compromise that comes along with it. The right side of the heart is not a really strong pumping system, and I'm sure you guys understand that by now. The right side of the heart equals a flow system, okay? And it's not meant to pump against a high pressure gradient or afterload. So when we're increasing our pulmonary artery pressure, we're increasing our afterload. So let's talk a little further about this and some of the contributions to what we're concerned about here with our increased pulmonary vascular resistance. So are we concerned about hypoxia or hypoxic respiratory failure secondary to pulmonary hypertension? Well, yeah. That is concerning, but that's not going to be what kills these people at the end of the day. It's going to be our hemodynamic compromise. So this is what's going to kill our patient in these situations, like an acute on chronic increase in pulmonary artery pressure or an acute increase in pulmonary artery pressure with someone with a healthy vasculature. All right. So let's look at how hemodynamic compromise and this whole cascade of cardiogenic shock, that's what we're going to call this, cardiogenic shock, comes about. Okay. So let's hopefully have enough room to do this. All right. So what happens in or two, let's say what happens to the right heart, or actually what happens to the system? In increased, let's make this a different color, increase mean pulmonary artery pressure. All right, so we keep talking about RV afterload, so let's start with that. So we're going to have RV afterload increase. Okay, we're going to have an increase in our RV afterload. And what is that going to do to our output? Since the RV doesn't like to pump against a lot of pressure, it's going to decrease RV output. So what's the decrease in RV output going to do? Well, we're all connected, right? What goes to the right heart has to go to the left heart. So what's going to happen if we decrease our RV output? Well, we're also going to decrease our LV preload. Okay? Because it all has to go through the system. It goes through the right heart, through the pulmonary vasculature, and then to the left heart. So if nothing goes to the left heart, then we're going to reduce our LV preload. And if we reduce our LV preload, that means we also reduce our LV output, so our cardiac output. Okay, so you can see a cascade developing here of just a cycle of demise. Increasing our RV afterload, we're increasing our RV dilation. All right. And if we increase our RV dilation, we're going to stretch our tricuspid. Just like if you had systolic heart failure and your mitral valve doesn't close all the way, you get mitral regurg after that, and it kind of propagates the whole scenario. So we're going to stretch our tricuspid, which is going to increase regurg. Okay? So what happens when we do that? Well, we're going to also decrease our RV output because we're not going to pump as efficiently, even less efficiently. This RV dilation is going to lead to a leftward septal shift. Is something that we call, or this interaction between the right and left ventricles is something that we call ventricular interdependence. Ventricular interdependence. Okay. Sorry, I can't read that. I'm running out of room here. But ventricular interdependence. So ventricular interdependence, if you look at the heart, we'll look at it from a top-down view. So usually if you look at the heart in like an ultrasound or an echo or something, you're going to see, you're going to see your LV kind of looks like a circle, okay? Because it's a nice thick muscle that likes to pump. And then your RV, we'll do in this kind of blue here, is going to look like a crescent, okay? Because it's a floppy thing, but it does its job. We're not making fun of it. So RV and the LV. So what happens in these situations with RV dilation and this leftward septal shift, right? There's a septum in between these two. You're going to have a change, kind of a morphology that's prevalent in pulmonary hypertension that's severe, and you're going to have a shift where it looks like you have this big old bubble here as your RV, okay? And then your LV might take on this crescent type shape, therefore reducing its capacity and therefore reducing its output, okay? So this is the idea of ventricular interdependence, and this is important because the RV and the LV share the same pericardium, they share the same septum, they share the same fibers, so whatever happens on one side is going to affect the other. But in normal situations, our LV pressures are much higher than our RV. This also comes into play when we talk about congenital lesions and things like that, but that's out of the topic of this discussion. All right, so we have this leftward shift, septal shift, which is also going to decrease our LV output, okay? And then a decrease in LV preload is also going to propagate this leftward septal shift, okay? Because if there's less pressure in there, there's a higher propensity for the left side of the heart to shrink down and be affected by this, and therefore reducing our LV output. All right. So let's think of some things that would further affect this cascade, and I have a whole bunch. Let's talk about some things that cause increases in pulmonary artery pressure real quick. All right, let me put these over here. All right, so we can have hypoxemia. We can also have ARDS. We have pneumonia. We have COPD, which is a very big cause of this elevated pulmonary artery pressures. And then we have an acute PE, all right? And these are the ones you really worry about. So an acute massive PE. We can also have cocaine use and meth. And then also people who stop their medicine. So stop their pulmonary arterial hypertension meds. So that's like the group 1. And we'll get into the WHO groups of pulmonary arterial hypertension in this module or in this week. So all these things can cause it. So what else can increase RV afterload? So let's say we intubate this patient. Well, now we have our mechanical ventilation, right? So let's say vent pressures. Okay. And also what can cause this RV afterload is atelectasis. Increase in RV afterload. And the way that works is that when the alveoli collapse around the vasculature, it causes a higher level of resistance. So therefore, that's going to increase RV afterload by increasing your pulmonary vascular resistance, which we established in that previous equation, is a major factor in determining this. So ventricular vent pressures that are too high, inadequate PEEP, or too much PEEP, either way. So the ventilator really plays a huge role in dealing with these patients. You can kill them with your ventilator management. If we're increasing our RV afterload, let's do this in a different color, we're also increasing our RV O2 demand. And with an increase in RV O2 demand, and also an increase in RV afterload, we're decreasing our coronary flow. So if we decrease our coronary flow, sorry, this is getting messy, coronary flow, and we have an increase in oxygen demand, we're going to end up with some ischemia. All right. And this is all a product of decreased O2 supply. All right, let's synthesize this really quickly before I move on. If we have an increase in RV afterload and a subsequent decrease in LV output, right, we're going to have a decrease in our coronary flow. Okay? With a decrease in our coronary flow, we'll have less oxygen supplied to the myocardium. And we'll also have an increase in oxygen demand due to the RV afterload. We're going to end up with the cycle of RV ischemia from that. So with this RV ischemia, we're going to further propagate our decrease in RV output. So you can see how this all kind of feeds into each other. Hypotension that happens from this cardiogenic shock will also decrease his coronary flow. All right. Now, an important part for us to know was all of this, but let's say we're intubating this patient, and this terrifies me the most when we have to intubate these patients who have these massive PEs, or they have pulmonary arterial hypertension, they're exacerbated by ARDS or pneumonia, or their COPD. You know, they could have these comorbidities that just present like an acute or chronic condition. So when we intubate these patients, all of this, we're going to further decrease our RV output. We're going to decrease our pressure, which means we're going to decrease our coronary flow. We're going to apply increased intrathoracic pressure. Okay, and we're basically going to worsen everything that we're seeing here. That doesn't mean we shouldn't intubate these patients, but we have to be prepared to deal with these situations afterward and actually intubate very efficiently, because there is zero reserve. And all of this is going to lead into this whole cascade and propagate that even more for intubation. So just be aware of that when we're intubating these patients with these acute massive PEs or submassive PEs. They can die during that process pretty quickly, and that's why it's a very tense situation. A few other things with this RV dilation over here, and oftentimes we'll see this in the ICU, excess IV fluid. Okay, and that makes sense, right? Because, you know, let's say they're shocky, they're hypotensive, we haven't really figured out what was going on with them yet, so they're getting some fluid. They're getting 500 cc's, they're getting boluses and boluses. Well, if the RV has nothing to pump against, or is pumping against the wall, basically, we're going to increase our RV dilation, which is also going to propagate all of this down here. And then furthermore, if we stop diuresis in patients who can't pee, so in renal failure or heart failure. So it's a double-edged sword. So you're kind of like, well, what can we even do with these patients? Well, we'll get into that in this semester, this week, but this is something we need to consider in critical care. And all of these things lead to cardiogenic shock. That's very, very difficult to manage. All right. And some management strategies that I've experienced, if it's a PE, let's just talk about the PEs for now. You can do thrombolysis. All right, and there's something called an EKOS catheter that you go to the cath lab, and they basically stick a catheter all the way up to the block, and they will put TPA in there. But also they can put a catheter in there that shakes, it vibrates, and it releases heparin very slowly in the clot and breaks down the clot. It's very interesting. Or you can do ECMO. All right. So recently I had a case where a 31-year-old patient came in, young guy, very sedentary, and ended up just not feeling too well, getting short of breath. They brought him into the hospital. And I think this was at down in Aberdeen or something in that area. And I was actually sitting pump at UNC at the time. And they consulted us for ECMO. So we went out there, we got him back over here, and he's about as white as a sheet. They go down to do this thrombolysis and do an EKOS catheter. Well, he ends up arresting because of all of this up here. All of this craziness that demonstrates his lack of reserve. He inevitably ended up on VA ECMO. And from there, basically we work on breaking down that clot and basically bypassing that clot and making it so his heart basically doesn't explode from the right side. So ECMO is a viable option, albeit we always want to make it the last option, but we don't want to wait too long, and preferably VA ECMO, okay? VV ECMO, if you think about it, you're just going to further dilate the right side of that heart by sucking blood from that system and pumping blood back into the system, and it has nowhere to go. So we're talking about PEs here. But let's say you had a PE and ARDS, PE and pneumonia, and you already had baseline pulmonary hypertension. Well, that's going to be a mess. So I've had patients die very quickly who were not diagnosed with this, but sent over from other hospitals, being recently diagnosed, and just moving them from one bed to the other, they pretty much dropped like a rock. And I've had the pleasure of intubating some patients in these situations. So you really have to know what you're doing when you're doing that. Granted, I'm not giving drugs or anything, but I have to make sure that tube goes in as quickly as possible. So this is a brief on pulmonary hypertension in the ICU that can generate cardiogenic shock. And I think it's something very important for us to know. I know this is kind of confusing here, but I think it also makes sense, okay? All you have to do is think about this as the whole system is fighting itself. And at the end of the day, everything's a very delicate balance with these patients. All right, if you have any questions, please let me know. Send me an email, call me, come to my office hours, whatever you need to do. Thanks for watching.